Oh, yeah. Regular.
Good afternoon, welcome everybody, bienvenidos y bienvenidas a todos. En portugués no puedo decir, sorry. So welcome to the, sorry, my languages are getting. Welcome to the Center for the Invited Speaker Series of the Drexel Center on Climate Change and Urban Health. And we are based at the Urban Health Collaborative here at the Drexel School of Public Health. And we are very fortunate today to have Chen from the Yale School of Public Health visiting with us. Kai is an assistant professor of epidemiology at the Yale School of Public Health, and he's also deputy director of the Yale Center for Climate Change and Health, which I think was probably among the first centers on climate change and health in schools of public health, if not the first. I don't know.
One of the very.
Yeah. So, so really, very forward thinking. In terms of thinking about climate change and population health. And Kai received his PhD in environmental science and engineering. So he has a science and engineering background in 2016 from Nanjing University in China. And then he was a visiting scholar at Columbia University. And before joining the Yale School of Public Health, he was a postdoctoral fellow in Munich at the, I cannot pronounce the name in German, at the Helmholtz-Zentrum German Center for Environmental Health.
Yes.
And he has done a variety of work in really documenting the health impacts of climate change. And I think that's kind of what you're going to talk about, how climate epidemiology, how to assess the health impacts of climate change, very timely also for our center as we try to, advance this kind of work here at Drexel University and also with our partners in Latin America. I also want to remind everybody who's on Zoom that you can hear the translation into Spanish or Portuguese by clicking on some button there. Right? Yes,
Interpretation, right? Yeah.
So Kai, if you want to hear your talk then in Spanish or Portuguese, you can do that. So thank you so much for joining us.
Thanks, Anna, for the thank you, and thanks again for the wonderful introduction and the invitation, and thank you all for coming. And it's my great pleasure today to share with you some of our group's work over the past few years on what now we call it climate epidemiology. And at the Yale School of Public Health, I teach a class called how to methods in climate change epidemiology. So I think here maybe I will just frame my talk into, with the question how to assess the health impacts of climate change. So you all know the news that, climate is getting warmer, and over actually the past 12 months has been the warmest months each month. And 2023 is currently the warmest year on record. We're going to see perhaps 2024 will be another record-breaking year. And then when we, talk about the climate change health impacts, so we can consider the different pathways that climate change can impact in our health. So many of you are familiar with heat waves, right? Heat wave is one of the most direct health impacts. But there are also other events like extreme weather events, like droughts, flooding, hurricanes. These are the events that can also directly impact our health. But also, there are other indirect pathways, and one of them is air pollution. So we often see that air pollution and climate change are really the two sides of the same coin. So whatever driving air pollution, the majority of fossil fuel also contribute to air pollution. Right, so the health impacts also comes from, both of them come from the same source, and air pollution is also a major indirect pathway that climate change can affect us. But also there are other, think about other pathways like water quality, like land use changes. All these things, they can impact not only on our physical health, but also on our mental health. And all these direct, indirect pathways, the kind of how interactions with our social dynamics, thinking about aging society or a lot of social inequalities that we are facing today, all these can interact with these kind of direct, indirect pathways impacting both our physical and mental health. And back in the 2009, when Lancet has first kind of commission on climate change health, they came up with this conclusion that climate change is the biggest public health threat in the 21st century. And today, after the COVID, we still believe this is true. And in 2015, when the Lancet countdown started, people framed it as the biggest public health opportunity, right, to address climate change. So you always hear people think, okay, climate change is the biggest health threat. But when we talk about the biggest, then you need to give people a number. So how do we actually know how much the health burden is due to climate change? So to answer that question, this is what I call the subfield of environmental climate epidemiology. That's the task what we do. At the what I call the Chen lab, the climate health environment nexus lab, what we do is using multidisciplinary approaches, try to look at climate change, air pollution, and all the other extreme weather events, use to look at the health effects, but also look at the potential health benefits if we are addressing climate change. So when you think about estimating the climate change health impacts, we can nail it down to very simply 4 factors. So first of all, you need to have your study population, right? And then you need to have the health outcome that you are targeting on. Sometimes we call it climate sensitive outcomes, right? But you need to know at the baseline, you know, the baseline mortality rate, the baseline health rate of your study, the population. And then the climate related factor that you're looking at, whether heat waves, hurricanes, drought, flooding. We want to know, you know, not only what the current exposure is, but also either the exposure has been attributed to the ongoing climate change, or in the future, what this exposure will change because of climate change. So we need to know the changes in the exposure. And at the very least, at very last, but the majority of our happy work is trying to provide the link between the climate-related exposure and health outcome. So that's why we provide the exposure response relationship. So once we have all these different factors, you know, we can calculate the health impacts from climate change. So based on that kind of simple calculation, we know that we can kind of classify the current efforts in climate change health to 3 major categories. The first one, obviously, we want to know about the exposure, right? And nowadays, people try to go to more and more granular scale of high resolution, spatially temporal about this exposure to reduce the exposure management error. And then, you know, the major task for us is to provide the exposure response functions for those understudied climate and health pairs. The third task is based on different scenarios, either in the past or in the future, we calculate the health impacts from climate change using results from the climate change modeling and the different socioeconomic pathway, climate scenarios, and also when we do these kind of calculations, we also need to take into considerations of uncertainties. Not only uncertainty from the climate models, but uncertainty from our epi work, uncertainty from the social dynamic population projection work, everything in the calculation. So that in the end, we can get the final health impacts. So today I will be just based on these 3 categories to just show some of the work we do in our lab in exposure response function, and also in the projection analysis. So in terms of the exposure, as you may know, like a lot of the studies, especially in the temperature health studies, are focusing on fixed monitoring stations data. And in the US, particularly, a lot of the data are actually from airport. And we know whatever you experience in airport, It's very, very different from what you experience at home, at work. So there is a large, what we call measurement error there when you look at the temperature measurement just based on the fixed site monitor stations. So what we really want is a highly spatial temporally resolved product that can allow us to estimate no matter where you are and no matter when you are. So the goal of this work is try to get us a much higher profile of the temperature. But this is, again, just ambient temperature. We have a lot more work to do in terms of getting to the personal level. But for this type of work here, just give you one example we did in Sweden. You can see here is the monitor station data. And it turns out like, although we couldn't get, the air temperature monitored outside your home, we can get such data for the land surface temperature from satellite. So satellite-based land surface temperature has been widely used to extend the spatial temporal coverage. But there's a lot of issues regarding the cloud coverage, everything, and there's a big difference between the land surface temperature and air temperature. So we need to build a statistical model to from the satellite data, from the monitor data, to get a more accurate air temperature data. So here what we did is using some statistical methods, including some machine learning approaches, try to fuse data to get us a highly accurate air temperature data. And after we did this, you can immediately see the difference within the same city. Like rather than seeing the city, everyone in the same city experience the same temperature, you can actually see the difference in people living in urban center versus people living near the parks, near the river, right? So you can see this exposure differences. So what's the benefits of having that high resolution data? Well, having high resolution temperature data can, first of all, help us reduce it, exposure measurement error for epi work. But also it can allow us to do more finer spatial kind of examination of the exposure disparity. So this just illustrates one of the work we did in the US, to look at the sensor track level vulnerability to heat. And here in this work, we are using not the land surface temperature, but the air temperature in each of the sensor track, combined with a bunch of other land use variables like green space, and also social economic variables like percentage of elder people, people below poverty line, etc. So we create this what we call the heat vulnerability index. And then it is at a sensor track level, so you can take a look at much granular spatial scale. And once you have that data, you can compare with other social economic data. For example, here we did a work look at the redlining for the grade B, which is the red line neighborhoods. They tend to have much higher vulnerability to heat. And then if you look at different population decomposition, it turns out the minority groups indeed, on average, has much higher vulnerability to heat. So it can help us reveal some place-based but also racial ethnic disparities. This is early work that we do publish in a paper, but then we try to make it as can be used as usable as it can. So we make it first of all ArcGIS story map, and then you can actually scan this QR code to go to the web page to put it in your own sensor track name or your city name to find out what's your neighborhood's heat vulnerability indexes. And if you're interested in using this data, we actually in the paper we actually provided the Excel file for the final heat vulnerability index we calculated. What we do in Explorer is looking back, but if we're looking into the future, we need to use the work from the climate sciences. So here just shows the climate change projection data from 18 different what we call global climate model or general circulation model, GCMs. And you see here, this is the historical data, and then the trajectory downwards and the different what we call climate scenarios. Here in the most recent IPCC report, people are using the scenario called shared social economic pathway, SSP. And basically SSP 5.5 is a very, very high emission scenario. SSP 370 is another moderate to high emission scenario. So once we have the data, so you may wonder, like this large kind of range, these are actually from different climate models. And one climate model could also have different kind of runs of simulations. So it really has large uncertainties. But we take that into account, and then in our work, a lot of the analysis we do are at city level or even more granular level. So although the global average temperature is at, let's say, 2 degrees Celsius, but what does it mean here in Philadelphia, right? In this district, right? So we need to downscale that global temperature projection data to the final spatial scale that we want to use. So here just shows one study we recently did in about 800 locations around the world. When the global average temperature reaches 1.5, 2, and 3 degrees Celsius, what the local average temperature will be. So we apply some downscaling and bias correction analysis to get these kind of location-specific temperature distributions in the future. Okay, so the next chapter, which I will be mainly talk about, is explorer response functions. And as majority of our work focus on temperature, air pollution, and extreme weather events, so I will divide the talk into these 3 aspects. So when we talk about temperature, I think you guys are all familiar with the temperature impacts on mortality, right? Just as wonderful paper shows in Latin America, you have both heat and cold effects, especially when the heat affects different locations differently, right? So then you may wonder, like, why does heat can affect total mortality, right? So one way to look at it is to look into each different cause of death and morbidity to see how heat and cold can actually lead to all the different health outcomes. So here is one of the work that we look at registry or the heart attack patients in a small German city called Augsburg. So we have data almost 30 years. When we look at the patient's data to try to link the temperature variation and the heart attack onset, we found in general, if you couldn't see the confidence interval here, but actually the heat exposure has a significant impact. So we see kind of the same U-shape for both cold and heat. That heat can indeed trigger the onset of these heart attack events. And we have looked into the specific population groups to see which population are more vulnerable. In the beginning, we see some of the evidence that certain population, like people who have pre-existing diabetes, they are more vulnerable. But then we try to see, okay, there are people taking some certain medications. And some of the medication we know from the mechanism might make people more vulnerable to heat. So that's why we ask the question, are there certain medication that this patient take makes them more vulnerable? So we did an initial analysis, basically stratify the people based on the medication they take. And what we found is the red lines for patients taking antiplatelet medication or beta blockers, they tend to be having higher risks during the hot weather. So this is just one of the initial step. There's a lot of questions regarding this. People didn't take medication for no reason, right? They have certain chronic illness. So how to adjust the confounding by indication, etc. These are the things that we're trying to address in our current work using a US cohort data. But there are many other diseases as well. For example, stroke is one of the diseases that we know for a long time. It can be associated with heat exposure. So here just shows one very early study we did in Jiangsu province, China. We see that when temperature goes up in the summer, you have stroke mortality increase for both types of stroke, ischemic or hemorrhagic stroke. And recently we have other analysis ongoing in the US using some Medicare, using some electronic health records data to show actually high temperature also can increase the emergency room visits for stroke. Here just shows another study when the heat effects goes beyond just the cardiovascular system. If you look at kidney disease, we did a study using the 4-stage emergency room visits in New York State, and we look beyond just the acute kidney failure or the chronic kidney disease, including other types of kidney diseases, and some of the diseases that not necessarily people considered before, like volume depletion. What we found is, when temperature goes up very high, the acute kidney failure, then ischemia and volume depletion, urinalysis, they all have significant increased risk. So we know heat has a major role to play for kidney-related diseases. But one interesting thing, we did a lot of things in this paper, but one interesting thing we did is we actually, because we have a really high resolution 1 kilometer data, so we'd be able to try to do some analysis to say, hey, if we use, based on the 1 kilometer data, to get a 10 kilometer interpreted to 50 kilometer data, to see if we're using a coarse resolution data in analyzing the short-term effects of temperature, would the spatial resolution play a major role? So as you can see, majority of them, they overlap. That means when we're looking at the short-term effect temperature, especially heat, well, the main driver of the exposure contrast is a daily variation, right? So although, let's say, airport temperature and your home temperature may be, in terms of the difference, atmosphere scale can be a few degrees difference, but you all both vary every day simultaneously. So it illustrates that for the short-term studies, looking at the temporal variations, actually, the way we did before, you rely on weather stations or maybe a 10 kilometer grade cell like the EI5 data globally is not that bad. So I think it kind of reassuring for the previous exposure assessment. But it does matter for long term when we study cohort studies, then that will be a big difference. So we did analysis, look at mental disorders. We are surprising to see that heat not only increased the overall mental health disorder, like emergency room visits, but if you look at major categories, anxiety disorder, mood disorder, or even substance abuse, they all have significant increases in New York State. So I think that's very surprisingly, and one of the things we hypothesized maybe the background of the mechanism is during very hot days, hot summer, you can't sleep well. Then we know sleep has a direct link with mental health. So that may be something interesting to look at in the future. Then talk about extreme weather events. One thing we did to look at the impact of drought is using a data set called demographic health survey data. We be able to use that data in 51 low middle income countries and to look at the link between drought experience and childhood outcomes. So here in this study, we look at a childhood diarrhea risk. And what we found is that not only the extreme level severe drought can lead to increased risk for childhood diarrhea, but also moderate drought can also lead to increased childhood diarrhea risks. And then when we look at with another end of the extreme precipitation, if you have too much precipitation, you end up having a lot of flooding events. So it turns out, for these flooding events, a few weeks flooding exposure can also lead to significant increased childhood diarrhea risk. And in this study, we also found something interesting that if you experience a drought first and then having a flood exposure, that risk is much higher compared to if you don't experience a drought event. So that really highlights the impact of compounding events. So compounding events not just co-occurring events, but also kind of temporary sequential like compound events. And in terms of flooding, a lot of the work has been done is focused on low middle income countries, with the understanding that maybe the findings from these low resources sightings may not be directly applicable to the developed countries like in the US. So we try to see if that assumption is true. So we'll be able to gather the some mortality data in North Carolina, and we're trying to use NOAA-defined flooding events database to see whether there is flooded or not for a certain county. And we did this traditional time series analysis, and it shows that very surprisingly that when we hear the flooding stories on the news media, it's always injuries, drowning, right? So that's why we expect for accident mortality, you're gonna have a significant increase. That's true. But when we look at other systems, especially cardiovascular respiratory disease, we also pick up some signals. But most surprisingly is when we look at mental health mortality, they have the highest risk. So I think this is one thing very surprising, but also it could be explained by several mechanisms through either like the health service disruption or through some physical health increases. But overall, I think there's still so much unknown in the full burden of the flooding exposure. So I think hopefully more and more research can help us and understand what's the true burden, what's the true flooding related health burden in both the US and around the world. The third main area we do is air pollution. So I come from China. China used to be very, very severely polluted. So that's why we have an interest to look at pollution. And over the past, I think, 3 decades or more, the whole air pollution epi field has really demonstrated the links between air pollution and almost all the organ system diseases. And we, did some of the work to try to contribute to that knowledge. For example, we found air pollution can lead to mental health emergency, mental health outpatient visits, and pregnant women when they have high air pollution, they may suffer more from mental stress. And some tiny particles called ultrafine particles around like 100 nanometers or less, they could, penetrate into the lung, go into the body, circulate around, and then trigger heart attack events. And then larger particles like PM10, PM2.5, they all are linked to kidney diseases. Among the air pollution studies, one I want to highlight is a recent work that we did in actually North Carolina using the whole public school system's children's test score data. So we're trying to see if air pollution has anything to do with academic performance, because we have seen a lot of studies showing air pollution impairs cognitive function for older adults. But what about children? So we did this study, and it turns out the long-term air pollution, as you can see, higher than 8 or 9 microgram per cubic meter annual level, you really see adverse impacts for both mass and reading scores. So we did this study actually before the EPA updated the annual guidelines. So when we actually write this, we say, at that time, the EPA air quality guidelines, 12 micrograms per cubic meter is not stringent enough. But I think this is one piece of the emergence studies trying to show the overall air pollution impacts on the cognitive function in early life stage. Another study I want to highlight is a study that I had a pleasure to work with the multi-country, multi-city network when I was at the end phase of my postdoc in Germany. So they were at that time starting this kind of short-term air pollution and mortality studies. One group will focus on particulate matter, one group will focus on ozone. We were basically asked, are you guys interested in doing carbon monoxide study? And that was No, I'm not interested because carbon monoxide, when we do air pollution, is such an old topic. And if you look at the US EPA air quality guideline, carbon monoxide the guideline hasn't been updated for like 50 years or more. But PM has been keep updating. So and that's why I'm not that interested. But since I was given that task, so we've been working on that, and we collect the data on around 300 cities, and you can see most of them are not from Latin Americans. There's only a few cities in Chile has some data. So we'll be able to look at this data, and surprisingly, if you look at all the concentrations, majority of them have very low level of carbon monoxide, which kind of confirms, because when we think now ambient air pollution, carbon monoxide is not the concern, right? It's in people's mind. So it's more likely to lead to indoor poisoning, right? When you have the gas leak or other things. But surprisingly, we indeed pick up some signal when to see a few days exposure to carbon monoxide at a very low level. Even like we have a exposure response function to show even below 1 milligram per cubic meter, that can significantly associate with increased mortality risk. So I think that also gives some thing that surprisingly, maybe we should consider revise the carbon monoxide air quality guideline. And then I don't take the full credit, but this study was eventually being cited in the updated WHO air quality guideline that for the first time they included an ambient guideline for the carbon monoxide, and our kind of analysis results was helped a little bit to for them to define the full milligram per cubic meter threshold. But as you can see here, most of the cities already meet the WHO guideline. So even for the new guideline, actually they're not that stringent enough for carbon monoxide. So talking about air pollution, then another thing we have to talk about now is Wi-Fi. So last year you recall, here is in the New York City, we see the orange sky, which is something before we only see in the West Coast. But now it's because of the Canadian Wi-Fi. So we see on average in New York City, the PM level is up, on average can increase more than 150 microgram per cubic meter. Nowadays, you don't have more, you have less than 10, right? So that's a huge impact. So when we look at this, we say, okay, that because we are working on Wi-Fi, so we know it has impacts on our health. And among all the different health outcomes, actually, asthma is one of the mostly well-linked outcomes. So we did this study to use near real-time syndrome emergency room witness data from New York City, and we found that actually more than about 40% increase during that 3 days of smoke wave. The emergency room witness for asthma increased. So the main purpose of why we did this is not because we don't know Wi-Fi has impact on asthma, but we want to, first of all, raise awareness for the public. When they think about these things, Wi-Fi happens, oh, it's nice orange sky, take a picture and that's it. But it really is a public health threat. So that's the main message we want to convey. But the second thing is, what I really hope is the local governments and local departments of health, when they see this future climate-related emergency, they can actually do something like this. They can make this kind of analysis operational in their departments. Not that complicated analysis. But nevertheless, we have more and more analysis showing what is the true national burden of Wi-Fi over the recent years. So the number may surprise you, and I hope to share that with us later. But then, when we came into the final health impact, when we have everything ready, we can calculate the burden. But first of all, we can look at what's the historical burden has been, right? So for example, temperature, we can do the analysis on temperature, heat, and cold associated with all the different organ systems, and then we can calculate how much burden it contributes to. So this is one of the studies we did in Jiangsu, China. We found, like, as you read from the literature, more cold-related mortality burden, overall, in this study, we found like around 10% of the total mortality can be attributed to heat and cold. This is largely in line with what the current literature has shown. If you read the most recent papers on the global burden disease study, they use different approaches and potentially underestimating the coding burden, but still they get a number of roughly around 2 million deaths per year. Could be attributed globally to heat and cold, but there's other estimates showing that this 5 million deaths per year. So the number may be slightly disagree with each other because of methods, because different group using different data sources, but the magnitude is in agreement. So we are indeed seeing millions of deaths every year. But again, I want to emphasize this is the air temperature related mortality. It's not climate change. So because we have to do what we call the attribution study to find out what are the proportion of the current temperature related burden to climate change. And another thing we did is, when we think about temperature, it's not just the average daily temperature. It's also about the temperature variation. Could be the maximum minus the minimum temperature you experience per day, the diurnal temperature range, or a few days extreme variations of temperature. So here we did a study in African countries and found that temperature variability can actually account for about 7% of the low birth weight. And there are other studies actually showing the additional independent effect of temperature variability when you already control temperature, and that can also lead to substantial increases in mortality burden. So when we go to air pollution, I think there's so many studies have shown air pollution burden. You see it all the time. But I want to highlight one study we did recently with the focus on the racial ethnic disparities. So in the U.S., we all know is that over the years, because of Clean Air Act, the air pollution has been dramatically reduced, right? So most of the U.S. has seen air pollution reduction, which is a good news. And but when we look at the PM2.5 related burden, for example, here we'll look at PM2.5 and cardiovascular disease mortality. And if you did an analysis stratified by different racial ethnic group, you actually find out the largest burden, the largest impact is for the non-Hispanic Black group. So that means they are more vulnerable, they have high risks. And if you do the burden calculation, so from 2001 to 2016, air pollution is decreasing. So among all the groups, we have the decreasing PM2.5 reduced cardiovascular mortality, which is good news, right? Success. But so you see that the largest burden is from non-Hispanic Black because they have the highest risk. They also have the highest baseline risk, baseline mortality. So you also see a large reduction in this group, which is also good news, right? So everything seems good until now. So when you look at the difference between Black and white, when you look at the absolute difference, you can see a large reduction here from between 2001 and 2016. So what we can say until now is the absolute disparity between Black and white in terms of PM2.5 attributable cardiovascular mortality burden has been dramatically reduced, right? Thanks to the PM2.5 reduction. However, if you compare the relative disparity, that is a ratio between the Black versus the white, their PM2.5 attributable burden, it barely changes. And the same thing goes for the Hispanic, although it's just 1.3, 1.4, but still significantly higher than the white people. So what we learn from this is actually the relative disparity stays. So that means although we have very successful environment policy, but if we do not design the future policy with racial ethnic equity in mind, then you will continue to achieve the absolute disparity reduction, but preserve the relative disparity. So that's one is this kind of analysis can show. And then let's consider the future. So here I will just use two examples. One is focused on temperature mortality, while another is using ozone pollution as an example. So when we project the future, it has been a lot of studies just doing the thought experiment, saying if we only consider climate change, what's the future temperature-related mortality burden will be? Then you keep population the same, you use all the things that you developed for the historical period, which is a useful argument to isolate the climate change impact. But another important thing is the world is not just changing with climate, right? We have other social dynamics going. And one of the important trend is aging. So when the world achieves, let's say, 3 degrees Celsius warming, if you look at different locations, when the 3 degrees Celsius warming was achieved, actually the percentage of people more than 65 years old will dramatically increase, especially in some of the developing countries like here, Latin America and the Caribbean countries. You will see more older adults in the population. So what does that mean? Well, if you look at the temperature mortality association, and if you divide by age groups, it turns out older adults are more warm. They're more vulnerable not only to heat, but also to cold. And if you're familiar with a lot of temperature mortality burden analysis, the largest burden is actually from the moderate cold, which is reason because you have way more days experiencing this moderate cold. So despite the relative risk is not as high as extreme temperature, but you have way more days experiencing that. So that's why when it comes to burden, the actually is the majority of the temperature-related burden. And that brings a question, because people always say, well, in the future, heat-related mortality increase, but you also have reduced cold days. So you're telling me that cold plays a larger role in mortality burden, then can I expect in the future there's more cold reduction in mortality burden than the heat increase? So some people will actually say, oh, maybe in certain locations, this climate change is a good thing. There are many studies trying to disprove this by showing, it's not true. When you have a high emission scenario, you actually have higher increases in heat-related burden than reductions in cold. But what I would argue is that if you consider the aging trend, so when you have a more older adults in the future, the overall population will be more vulnerable to both cold and heat. So if you can take that into consideration, what if that the change will be? So here I'm showing this graph is from Bavaria, Germany, and then we see many most of the data is from the MCC, so majority is from the developed or high income countries. We did see in many locations, older adults are more vulnerable. So if we factor into the population aging with climate change, so here let me quickly explain for different countries under 1.5 degrees Celsius for the cold-related mortality burden changes. Because we're going to get warmer, less colder days, so indeed, majority has reductions in cold-related burden because of climate change. But on the other hand, we have more older adults that are more vulnerable, so they can largely offset that reduction in cold-related mortality. And when you go to more additional degree warming, you are also going to have more higher proportion of people more than 65 years old, right? So you actually have much larger impact from population aging. And on average, this is a study using this 800 locations, and majority from the US and Europe. So when you average them together, you can see the net change in cold-related mortality burden it's not actually decrease, but actually on average increasing. And the more global warming you get, the higher degree, the high percentage increase it will be for COVID. And then when speaking of heat, population aging will amplify the climate change impact. So will make the heat increase even larger. And then combined together, we see both increase in heat and cold. Then combined together, you will actually see a net increase across different scenario and across different region. So if you try to compare the climate change impacts and the population aging, very surprisingly, from the number, we can see that for example, at a 3 degrees Celsius warming, the final net increase in temperature-related mortality is majorly driven by population aging. So I think this is a factor that we shouldn't ignore when we consider the future impacts. Likewise, the same story applies to air pollution. So here I want to bring the attention to ambient ozone pollution, because when the climate gets warmer, you tend to have higher ozone pollution in already polluted urban areas, primarily due to ozone is a secondary pollutant. When temperature goes up, the chemical reaction rate increases. Some of the natural precursor of ozone, like nitrogen oxides and volatile organic compounds, they might increase from forest fire, lighting, etc. So it turns out that climate change will increase ozone in already polluted regions in many cases. So here we also in around more than 400 cities, we found that this is a very, very low emission scenario, kind of SSP 126 that can achieve the Paris Agreement. But other than this scenario, all the other SSP scenarios will have increased ozone pollution. So same story, if we look at the short-term ozone-related mortality burden, it turns out the older adults are also more vulnerable. So here just show one of the recent study we did in China. As the story like the temperature that before when we do the air pollution study, most of the data is from the air pollution fixed monitor stations, and they are in cities. So majority of the work before was only focused on urban areas. But nowadays with the satellite data, with machine learning approaches, we can get a full spatial cover exposure data for ozone as well. So then we'll be able to look at the ozone mortality in both urban and rural areas. So we found that, first of all, it impacts both urban and rural population. Second of all, the older adults, indeed, they have a higher mortality risks. And then when we factor this into the calculation, the future ozone-related mortality burden. So first of all, the climate change impact. Well, the climate change impacts, in the future, depending on different future climate emission scenario, in some scenario, like here, the ISB 4.5 in China, you actually have a reduction in the emission that leads to reduction in the concentration of ozone. But on the other hand, in the highest emission scenario, you have an increase. So that's what we know and the different scenario. But if you factor into the population aging and factor into the fact that in the future, the life expectancy is increasing, and then the age-specific mortality rate is going to decrease because of that. So that actually represents a whole body of improvement in the healthcare system, in the society, etc. So that's a benefit. But if you consider the offsets by these benefits, overall, we still see a net increase, no matter in the moderate or high emission scenario. This is largely driven by population aging. So here in this specific study in 140 Chinese cities, we found that population aging leads to a net increase in about 1 to 4 times by the middle of this century. And very recently, we by collaborating with this multicultural multi-city network, we'll be able to extend that analysis to 400 cities. And we found similarly, if you factor into the population demographic changes, we're going to see an increase in majority of the projection scenarios. Now, one of the difference here in this study is when we are using this multi-country, multi-city network analysis, we don't have age stratified ozone-related mortality risk. So here, in considering the population aging effect, we kind of factor into the population aging into the baseline mortality rate, because overall, if you can look at overall population mortality rate, we have older adult more aging society, the overall mortality rate will increase. So that's why, compared to the red dots, the emission actually in many countries, the baseline mortality rates increase because of aging actually is plays a larger role. So here in this study, we basically found that unless you can really achieve the SSP 126 that is a very low emission scenario, keeps the Paris Agreement alive, otherwise, we'll see a large increases in the ozone-related mortality burden. So to summarize, we know climate change in the house, but how? So here I show some of the example we did for direct impacts and indirect for air quality, and some of the interactions with aging, with some social disparities. But there's more and more work needs to be done. And I think during the discussion with the PhD students, some mentioned the kind of interactions between different factors and compounding events. So these are all the complex kind of causal web that we need to evaluate to really review the full burden of climate change in the house. But as the old thing saying, you don't turn the direction of your ship if you already see a tip of the iceberg, right? Look at if you are in the Titanic, if you see the tip of the iceberg, probably too late to change your course. So we don't need to wait until we fulfill the full burden, review the full burden of climate change. So I think what the society should do is work on climate change mitigation and adaptation. And our researchers' responsibility is trying to put more evidence for these two actions. So before I end, just two kind of advertisement. One thing is I'm part of this US climate working group on climate change and health. We have multiple responsibilities, but one of them is actually trying to listen to the community doing climate change and health about the things you think about the data, availability, data management, or when you do the analysis, how to factor in to the climate policy, or as epidemiologists, how to better understand and use climate data. So these are things we try to work on. And if you have any suggestion, you can talk to me or write me email. That would be greatly appreciated. Secondly, advertisement is Jack. We have a new editorial team. So I'm proud to work with Harlan Kromholz as an associate editor working on environmental cardiology. So if you have some great paper, consider Jack as your the target editor. Thank you very much.
Thank you. That's a terrific body of work that you produced, super comprehensive, very timely. We have some time for questions or comments.
Question online.
Okay, go ahead.
If you want to ask it. We have 3 minutes, but there is a class, right?
Oh, okay.
So, a question from Ale Vives from our team in Chile. She's asking, the study of myocardial infarction and medicine, is it the medicines or the type of underlying condition that explains the higher risk among those in medication?
Yeah, that's a good question. So in the German analysis, when we try to analyze that, we didn't find much evidence of the indication of the compounding by indication, but it doesn't mean in a larger population it won't. So that's why we're trying to see if we can replicate that small also cities analysis to a nationwide US cohort, and it might involve some more advanced analysis to better control the people have pre-existing condition and taking medications.
Other questions? Can I ask what? Do we have time for one more? What Hi, what's your vision, sir? What kind of research do you think we really need now?
So, so,
Loaded question, but if you
Yeah.
have any thoughts,
yeah, I think if you think back to the evolution of epi field, I think the challenge the current has been facing in recent years is the causality. So climate change and health, majority of the work is association or association analysis, because by nature, we cannot do a lot of this really complicated random control trials studies. But there are methods now emerging from the causal inference that allow us, to try to see if we can make some causal relationship, especially for this kind of seemingly extremely large mortality burden for temperature, for flooding, or from other events. So I think that's one immediate step. But another immediate step is how do we intervene? Like, what are the most effective intervention strategies? There are some research that needed really truly collaborative work with local communities that can be helpful. But there are also other studies that can be done, from data science perspective that can help identify whether or not certain existing policies are working or not. So I think these two are the current trend.
Great, thank you so much. Thank you very much.